All right. If we're massaging the uterus every 15 minutes and it remains flaccid and the patient is passing large clots, what do these signs indicate? The uterus is flaccid and passing large clots. That's good. That's uterine atony, and that is the #1 cause of postpartum hemorrhage. During the postpartum period, the fundus of the uterus is expected to go down normally about how many centimeters per day? Okay, so a centimeter a day. I do think your book says 1 to 2, so that might be why you're thinking 2. But usually it's about 1. So we usually do it in finger widths. And so one finger width is considered a centimeter, 1 finger breadth. When the uterus is firm and contracted, but there is vaginal bleeding after delivery, the nurse should suspect what? Okay, if we're having bleeding, but the uterus is contracted, then maybe we have a laceration that's bleeding. Okay, and so that is the best choice as our #2 cause of postpartum hemorrhage. The nurse notes that the mother's temperature is 100.2 after delivery. Which action is most appropriate? So guys, if she has a temperature, now this is less than 100.4 also, and we're less than 24 hours after delivery. If we're more than 24 hours after delivery and her temperature is going up, if it's greater than 100.4, that's diagnostic of an infection. For a patient whose temperature is lower than 100.4 and or they're less than 24 hours after delivery, she's probably dehydrated. Okay, she just had all these fluid shifts with giving birth, and so hydrating is going to be the choice for her. The nurse knows that the lochi is red and has a foul-smelling odor on the first day for a postpartum patient. The nurse determines that this is what? Okay, what kind of infection do you think would cause a foul-smelling odor?
I'm not sure.
Isn't it called like endometritis?
There you go.
Ah,
So if we're getting a foul-smelling odor, then we're thinking that it's because that's in her discharge, right? So we're thinking that it's an infection on the inside, and that's endometritis. You are right. Then a nurse is monitoring a postpartum woman who had epidural anesthesia for a vulvar hematoma. What finding would best indicate that she might have a vulvar hematoma? All right, so the most common symptom of a hematoma is pain. But the reason that wasn't the best choice for this question is she has an epidural. So she might not be feeling that pain yet. So the choice of changes in vital signs, what might we see if she was losing blood into a hematoma?
Would it be a low blood pressure and increased heart rate?
Yep. Good. But pain is usually the first symptom. Methogen is ordered to treat postpartum hemorrhage. Before administration, the priority assessment is to check what? Okay, why are we checking blood pressure for this?
Does it
Because
lower
it's
blood
a
pressure?
vasoconstrictor.
Good. So methogen causes vasospasms. So if you have a patient that has hypertension, then it can cause them to become severely hypertensive. So it's contraindicated. Which of the following findings would be expected when assessing the postpartum client? Okay, the fundus is a centimeter above the umbilicus an hour postpartum. Okay, that would be what we would expect. If on these other choices, a centimeter above the umbilicus on postpartum day 3, that would be too high. All right. Fundus slightly to the right and 2 centimeters above the umbilicus on postpartum day 2. What do you guys think that's describing? The green one.
With the bladder being,
Distended.
was it? Yeah.
Yeah, because now we've deviated from midline and we've raised. And actually, as you guys were playing, I searched in the book under involution for what the book says for how many centimeters per day that it should go down. And so this is what it says. It says, at the end of the 3rd stage of labor, the uterus is in the midline, approximately 2 centimeters below the level of the umbilicus at the very end of delivery of the placenta. Then the fundus is resting. Within 12 hours, the fundus can rise to approximately a centimeter above the umbilicus. By 24 hours, the uterus is about the same size as it was at 20 weeks gestation. Involution progresses rapidly during the next few days, and the fundus descends 1 to 2 centimeters every 24 hours. So for this, the fundus being a centimeter above the umbilicus, that's pretty common. But if we're deviated from midline or we're above the umbilicus postpartum day 2, that's not right. So that could be a distended bladder. What should the nurse's first action be when postpartum hemorrhage from uterine atony is suspected? Okay, so massage the fundus. That should be the first thing. If we see bleeding, we're going to assume it's atony, and we're going to start massaging the fundus. All right, and then we're going to have somebody else notify the provider. What other things might we do? So we start massaging. What would come next?
Get them to void.
Okay,
Yeah.
we could have them empty the bladder. If she's bleeding a lot, I might not get her up. I might have her either use a bedpan or I might use a catheter. But definitely managing the bladder is a priority. What else might we do?
Can you assess the blood, like the odor consistency?
We're assessing as we go. But
Okay.
if we're massaging and we're still having bleeding, we need more actions. We need to do more things. So if we've massaged and we've managed the bladder and we're still bleeding, yes, the doctor's coming. What am I going to be prepared to consider next?
Would it be like a blood replacement?
Probably not yet.
Would it be like something for to get the uterus to what are we trying to get the uterus to do? Contract?
Yeah. Okay. So what could we
Oxytocin?
do? Yeah. Oxytocin would be the next thing to consider.
Gotcha.
All right. And most of the time we have standing orders for that. And so there's a lot of things to consider. But if you just remember, I think of it as FFP, and I know FFP is fresh frozen plasma, and I don't mean give her fresh frozen plasma. I mean fundus, Foley, Pitocin. Massage the fundus, manage the bladder, so Foley or whatever, empty her bladder, and then Pitocin or oxytocin is the same thing, and get that infusing. And those three things should help the uterus start contracting. And if not, then we got to start thinking about our other medications and if we need to do other things. And then we can also look at blood product replacement and those things if we need it, depending on how much she's losing. So good job. The nurse notes a boggy uterus. The fundus is above the umbilicus and deviated to the side. What should the nurse assess next? Okay, the bladder. So we were just talking about this. If the bladder is full, it is oftentimes going to cause the uterus to deviate from the midline. Usually it goes to the right, but I've seen it go both ways. So usually the uterus is palpable in the center of the abdomen or like below the umbilicus, but in the middle, not off to one side. And if the bladder fills, then it will push up and then cause it to kind of deviate. And then often then it doesn't contract. That one was boggy. Massage and breastfeeding have been ineffective to control a boggy uterus. What order will the nurse anticipate? I didn't know I was giving out answers. So oxytocin would be the next thing we would anticipate to do. On this, it says massage and breastfeeding are not controlling the boggy uterus. Why might breastfeeding be something we consider?
The release of like certain hormones or something?
Well, it is releasing something.
Is it like estrogen or progesterone? One of the two, maybe?
Not quite. You're on the right track, though. What helps the milk
Nurse-
let down? When the mom is breastfeeding, what helps her milk let down?
The prolactin?
Prolactin tells the breast to fill.
Okay.
Oxytocin tells the breast to empty.
That's right.
Her body releases its own oxytocin when she breastfeeds. And so this is a great thing to do if what if you deliver a patient on an airplane? Put that baby on the breast. It's going to keep the baby warm and it's going to help her uterus contract. So if you don't have it right away, or maybe she came in and had a precipitous delivery and you don't have IV access and you don't have the oxytocin vials out of the Pyxis yet to give it to her IM, and she's got some bleeding going on and her uterus is kind of boggy, put that baby on the breast. Okay. A 4-week postpartum patient with mastitis asks the nurse if she can continue to breastfeed. What is the nurse's response? Those of you that have joined since the game started, the pin's at the bottom. If you're not in the game yet, you still can jump in. All right, so if she has mastitis, what's mastitis?
That will be an inflammation of this breast tissue or
Okay, so basically she's got an infection in her breast. All right, and so she can still breastfeed if this is infected. The problem happens really because it's very painful. Mastitis is a very painful thing. And so it's okay to tell her she can still breastfeed, but she might want to feed on the unaffected side first when the baby's more vigorous and then offer the other side. And truly, one of the things we encourage moms to do with mastitis is to keep that breast emptying. So if it's too painful for her to latch the baby on that side, she should even pump it so that she keeps that breast empty. Okay. Other thing too, for the two that joined that say Galaxy and Samsung, if you put your name in here, then I will let your instructors know that you came and played the game with us today.
Miss McBride, this is Katie on the Galaxy, I think.
Okay. And what
Sorry.
about the Samsung?
I don't think that's me.
No, that's not you.
Okay.
That's okay. And you guys, we don't have to do attendance for these, but I do let your instructors know when you come.
What did the yellow option say?
Oh, I lost it. The yellow
Okay.
option was I don't remember.
Okay.
I don't think I can go back. I'm sorry. All right.
It's me. I'm in there. Sorry, y'all.
A woman had a vaginal delivery 2 days ago and is preparing to discharge. What will the nurse teach the woman to report? Okay, why would we want her to report a fever?
Infection.
Infection. What about the change in lochia from red to white? Is it supposed to do that?
normal.
That's
Yeah,
normal.
normal.
That's normal. So lochia starts out red and bloody, and then it switches to what?
Like pink
Is
is it a
maybe?
pinkish?
Or dark red maybe?
Serious?
So it goes more to a pinkish. It's like a serosanguinous looking. It has pink because it's got some blood component to it, but it's a lot more mucousy. And then it goes to, and that one we call lochia serosa. And then it goes lochia alba, and that's the white. So that's normal. It's a normal progression. Fatigue and irritability is normal after you have a baby. The uterus is going to contract after delivery. That's normal. That's how it keeps, it involutes and it keeps bleeding from happening. And so fever is the concerning thing here. This patient is complaining of a reddened area on her lower leg. Her temp is 99.8. She has rust-colored lochia and sore breasts. What does the nurse suspect? Okay, phlebitis is what we're worried about. Okay, that temp of 99.8 is normal. The lochia is normal. Having breasts that are sore are normal. But the phlebitis, that reddened area on her lower leg, is concerning. Which statement indicates to the nurse that a postpartum patient understands the signs of late postpartum hemorrhage? All right, so here's what we're going to talk about with late postpartum hemorrhage. Late postpartum hemorrhage is something that happens after the first 24 hours. And so that's up to 6 weeks after delivery. So women might go home and then notice signs of subinvolution. So what's subinvolution?
Is it like when placenta fragments are still in there, maybe?
Okay, that's usually one of the number one. There's two main causes of subinvolution, and one of them is retained placental fragments. But what is involution? Let's start there. What's involution?
When the uterus goes back to before it was pregnant.
Right. So subinvolution would be the failure of it to do that. So it's not returning back to its pre-pregnant state. And so one of the causes of that is what Katie said with retained placental fragments. What else do you think can cause subinvolution?
Is it like an infection of the uterus?
And what's that infection called?
The
I-
endometritis.
Good. Endometritis. So endometritis and retained placental fragments are our big causes of subinvolution. And this is what's going to cause our late postpartum hemorrhage. So what they will see is going to be, we just talked about how lochia goes from red to pink to white. If it goes red to pink and then it goes back to red, that's not what it's supposed to do. That's a sign of subinvolution. Okay, so on the other options for this, bright red blood, large clots, those things are things we often will see with uterine atony right after delivery. But after that first 24 hours in the late postpartum period, we're looking at that lochia changing back to red. Okay. Which statement by the patient leads the nurse to determine a woman with mastitis understands treatment instruction? All right, so for those who selected yellow, why did you think yellow was the best choice?
Because the warmness of the shower will cause the milk to drop faster.
That's 100% correct. Okay, with mastitis, we're encouraging heat to help the milk let down and help keep that infected breast emptying. Okay, cold compresses are great for engorgement when the milk first comes in. And we don't want to nurse on the affected side first because that's more painful. And we do want to empty the affected breast, but we're going to empty it more frequently than every 8 hours. So the best choice for this is the warm shower to help that milk let down. The best response to a woman who tells the nurse she feels tired and sick all the time since I had my baby 3 months ago. Good. What are these potential signs of
Depression, postpartum depression.
postpartum depression? For a woman who had a cesarean birth yesterday, what action is most important to prevent thrombus formation? Okay, let's get her moving. Ambulation is a good plan for her. Five days after vaginal delivery, a woman comes in for a fever and persistent cramping. What is the possible cause? Okay, she's got a fever and abdominal pain. Endometritis. What else might we see with endometritis?
Would you see bleeding?
So we could, right? If we have subinvolution, we could see the lochia changing back to red, because by 5 days, she should be on lochia serosa. So if she goes back to lochia rubra, we could see that. That's true. What else?
A boggy fundus?
Maybe a boggy fundus, again with subinvolution. Maybe odor in her lochia. So the reason that so fever and persistent cramping, if they had said, so whoever answered blue, you think that's going to be bladder, right? So you're still thinking infection here, but you were thinking maybe the pain is from bladder spasms. Okay. And I can kind of see the thought process there, but considering she just had a baby 5 days ago and she's complaining of persistent cramping, I'm thinking that abdominal pain is more uterine. So that's why endometritis was a better choice. Okay, but you guys are right that we might have a boggy fundus. We might have some lochia rubra. We might be seeing signs of subinvolution because of the endometritis. So that's also true. After a prolonged labor, woman vaginally delivers 8-pound, 3-ounce infant. What complications should the nurse assess for? All right, so this baby, what do you think about the baby size?
It's large.
That's big. I could also get on board with yellow as a choice of a cervical laceration, but truly because it says that we had this prolonged labor and now we have this big baby, I'm not, if a cervical laceration is a tear in the cervix, and I usually see that with a precipitous labor that happens very quickly because the baby's coming down and through that cervix so fast, sometimes the cervix tears. With our prolonged labors with these big kids, more often the tissue trauma we see is the hematoma. Does that make sense? Maybe.
Yes, that makes sense.
Okay. A postpartum patient has lochia rubra times 2 weeks and pelvic discomfort. What's the usual treatment for subinvolution? All right, so dilation and curettage, what this is, let's think about first what's happening with this patient. So it says she's had lochia rubra times 2 weeks. How long should she have rubra for?
Only a couple days, maybe, right?
Yeah, so that's definitely not normal. And then she's got pelvic discomfort. And so that is leading to the suggestion that she has subinvolution. And remember that our typical causes of subinvolution are what 2 things?
Endometritis and placenta fragments.
Right. Okay. And so for this patient, it didn't give us any more information that would lead us to think that maybe she has endometritis. So it says what's the usual treatment for subinvolution, and we're going to be trying to get out the retained placental fragments. And so what they do with this dilation and curettage is they actually dilate the cervix, and then they go in and they clean it out. They clean the uterus out with the curettage. So it's like a little metal thing that kind of goes in and gently scrapes the inside and pulls all of that, whatever's retained, out of there. And so that would be the next thing to do. Okay. Now, I want to say, I'm thinking back to the previous question about the patient that had the 10-pound, 3-ounce baby and hematoma was the answer. If it had said laceration, a vaginal laceration, that I might also expect to see with that big baby in a prolonged labor. It was because it was a cervical laceration that wasn't the best choice. So I hope that makes sense too. So D and C is what we call this, dilation and curettage. We are 1 day postpartum. We've got temperature elevation, cough, and a slight shortness of breath. What action should be implemented? Okay, so this one, we're worried about the possibility of a PE. Okay, when we're this soon after having a baby and we're having shortness of breath and coughing, we're worried about a PE. So that would be the first thing to notify to rule out. It's possible that she just has an upper respiratory infection, but oftentimes these are viral and we might not see temperature elevations with that. I'm just worried that these other symptoms are signs of PE, and if we don't catch that, can be catastrophic. Vaginal delivery yesterday has a firm uterine fundus and a trickle of bright blood. How's the nurse react and respond? All right, if we're having a trickle and the uterus is firm, laceration's the next thing we're worried about. Okay. So if we're having this trickling, because if the uterus is firm, we shouldn't be seeing continuous bleeding. The nurse assesses a positive Homan sign when the foot is sharply dorsiflexed. Where does the patient report the pain? Good. So I want you guys to know what Homan sign is, because there are still nurses that do this. Okay, you shouldn't. That is when we talk about evidence-based practice, we've moved away from doing this. Why do you think we shouldn't do it?
You can make the clot move.
Yeah.
Mhm.
Okay, the concern with this is the possibility of a DVT. And if we are sharply dorsiflexing the foot to elicit a Homan sign or pain in the calf, we can make the clot move. And now we have a bigger problem because we can cause a PE. So I want everybody to understand what it is, but we're not doing it anymore. But nurses have been nurses forever might still do it. So you might get a report and she has a positive Homan sign. And so then you know what that means. The mother who had a vaginal delivery yesterday has a white blood cell count of 30,000. What action should be implemented? I'm not a huge fan of this question now that I'm reading it. All right, so she has a white blood cell count of 30,000. Is that high or low or normal?
Hi.
That's high. Okay. This is going to be one of those things that is one piece of the puzzle. So do we have other symptoms? Do we have signs of infection? Like, does she have a fever? Does she have, this is going to be something we want to notify about, but let's have a little more information first. Lay eyes on your patient and see if she's showing signs of infection, because sometimes white blood cell counts go up with labor and delivery. Okay, truly not usually that much, but I want to be able to say, okay, so this is her white blood cell count, and these are the symptoms that I am assessing. Cassie, you have a question?
Yes, please. What is supposed to be the normal white blood cell count?
Who knows the answer?
I think it's 10 to 20,000, or 4,000 to 20,000. 4,000 to
I
20.
think it's less than that. Let me look.
Is it 5 to 10,000?
That
5,000?
sounds like more along the lines of what I thought, but let's look it up. All right, so according to mountsinai.org, they're saying 4,500 to 11,000. So it's going to depend a little bit on your facility, because they'll give you the normal range. But basically, I would say anything above 10 or 11 would be considered high. But if I say what's a normal white blood cell count in labor, we're going to get a higher number. So this says 10 to 16. So it is normal for white blood cell count to go up in labor and delivery. Truly, this 30,000 is high for sure, but let's get a little more information and then we can contact our provider. Okay,
Okay,
so our
thank
white blood
you.
cell count is high, but do we have other signs of infection? Because that's what we would be worried about, is infection. That's why when I read it, I said, I actually don't like this question very much, but it's still one to think about, do I need to gather more information before I call my provider? A postpartum patient experiences anaphylactic shock. What is the most likely cause? Yeah, it's allergy. She's reacting to something. A woman's prescribed Coumadin for DVT. What will the nurse instruct as the antidote for warfarin overdose? Okay, so vitamin K is our antidote for warfarin overdose. What else do we use vitamin K for on labor and delivery?
For the
Give it to the
baby.
baby.
We give it to a baby, right? To help the baby's body start promote the production of their own clotting factors. The perineal pad of a 3-hour post-delivery patient has no lochia. What finding would the nurse expect on assessment? If I'm not seeing any discharge, I'm worried that her body is hanging on to it, that her uterus isn't contracting well. Because we should have some. So there's a difference between having like a constant trickle of blood and bleeding versus having some discharge after having a baby. And so if there's no lochia 3 hours after delivery, I'm worried that she's retaining stuff. And so I want to massage the fundus and see if it's firm. Some of you joined late, so it's not very fair in that regard. But Mikey's our big winner. Good job. You have an ice cream cone on your head.
This is what the next exam, like the topics of the next exam is going to be over, right?
Can be, yeah.
Okay.